Good evening and welcome back, friends. So today we are having the most interesting session again, mechanical ventilation. And today we have a very important session on alarms. So most of the time, like as juniors, we all have learned just to mute the alarm, but don't know how to monitor the alarm and how to set up the alarm. I think setting up of an alarm and detecting it at a proper time is very important as far as mechanical ventilation is concerned. So today we have Dr. Chandrasekhar with us. He will be explaining in detail about alarms and again troubleshooting. These two things are very basic and most important aspects of mechanical ventilation in an ICU scenario. So before that, we will discuss the questions as well. Uh, Over to Dr. Saneesh.
Okay. Okay. Good evening, everybody. Is there any echo problem? Fine. Okay. Fine.
Yeah, fine. Can continue.
We are about to start our alarms and troubleshooting, which will be module 7 of our mechanical ventilation series. Tomorrow we'll have a discussion on diagnosis and management of pulmonary embolism. Just to remind you regarding our YouTube channel, whoever is asking for the previous sessions, you can directly go to the YouTube, search for webinarCAMPUS channel. All our sessions are there, recordings are there in our YouTube channel. To get the downloads and updates, you are requested to join our Telegram channel. We have 3 different streams, one for our general audience, one specifically for critical care audience, and one channel for anesthesiology PG training program. Again, our Facebook page, just to remind you, it's available at webinarCAMPUS. You will get the weekly schedule and the YouTube links, because most of our videos are going live stream on the YouTube, and our upcoming programs and faculty details, and whatever feedback you want to give or any doubts you want to post, you can post in the chat. Whoever has already posted in our chat would have found that almost invariably we'll be replying within a day or two. So you can use this as a forum or a platform to give us the feedback or come out with your suggestions, queries, or comments on our program. So now I'll brief through the pre-test questions and answers. We'll discuss regarding the answers a little later. Just an overview of how our participants responded. Okay, the first question was a 50-year-old on volume control mode, ARDS, passive patient. Ventilator gives high pressure alarm. What do you do? Luckily, nobody asked the nurse to silence the alarm. Just one person, maybe by chance, put the option of ignore the alarm. So majority went with this option, identify and manage the problem, which actually we are discussing today. Second question was the high and low alarm limit default setting on a ventilator. Good number of people have gone with this answer, 10 to 15, above and below the normal values. 3, alarm fatigue management include all the following except, okay, what is not required. So 71% said that setting alarms 50% above and below normal limits is not required when we are troubleshooting alarm fatigue management. Question number 4, high pressure alarm can be triggered by all of the following conditions except. I think there is no confusion these days after having attended our classes and with your clinical experience, there is no doubt. Question number 5, patient on ventilator, high pressure alarm, saturation falling to 77%. What do you do? Include all the following except. Okay, so silence the alarm, majority prefer not to use. So it's now time to go to our today's lecture. Chandrasekhar sir is ready with the lecture. We'll listen to the lecture. After that, we'll have the interactive forum. You can come up with your questions. You can keep putting your comments or doubts in the chat box then and there. So we'll try to address that. And you can raise your hands to volunteer as an attendee for an interactive discussion. Over to you, sir.
Screen is visible, Saneesh. Slides are visible?
Yes, yes, fine, fine.
Okay. Good evening, friends. Today is the 7th module. As Anoop said, alarms and troubleshooting is very important because they're interlinked. Alarms are there to tell us there is some trouble, and the troubleshooting is ultimately for patient safety. There are 2-3 issues that upfront I want you to realize, understand, and keep it in mind. The troubleshooting alarms are important because we are already handling sick patients with a very low physiological reserve. So neglecting alarms and delaying any troubleshooting will eventually lead to increased morbidity and mortality. So it's on a sick patient, any alarms and troubleshooting has to be swift. So this is something you have to remember. And I will, in the course of my lecture, I'm going to tell you how to triage the alarms or the patient, how to know the criticality of the patients and how to or how much of an importance an alarm carries or what types of alarms is what is going to be the whole narrative about. This is a very interesting quote, isn't it? Purpose is an incredible alarm clock. So what I would urge is, when there is alarm, the purpose for us has to be patient safety. It is very important that no alarm should be neglected. But there are issues with alarms. There are issues with alarms. I will show you. And industries, doctors, everybody are working to make alarms more purposeful or kind of doesn't lead to alarm fatigue. So we'll just look at first 10 minutes about alarms, how to set and what is the issues with alarms we have on the ventilators. So when we say troubleshooting, obviously there has to be a problem, isn't it? If there is no problem, there is no question of troubleshooting. So we get to know of the problem with an alarm. So whenever an alarm comes, you trace back, there is a problem and you have to troubleshoot. Troubleshooting means there is a problem and problem is made known to us by a alarm ringing, which may be visual or audible, or can be both. It's usually both. So alarm setting is for patient safety and it should eventually end with the evaluation and management of the problem. Should never mute the alarm. That's the take-home message. The first slide and the last slide would be never mute alarm. By correction of the problem, the alarm has to stop. That's the bottom line you have to realize. Otherwise, let it ring. At least if you don't appreciate, somebody might appreciate. A respiratory therapist might appreciate. A nurse may appreciate. A doctor may appreciate. So never ever close the problem. Once you close the problem for 2 minutes and twice 2 minutes, the brain may be damaged by the time we realize there is a problem. So don't ever mute an alarm. The alarm has to go when the problem is sorted out. It's an alarming problem, isn't it? See, look at the amount of devices we have per patient, then combined with, look at the number of beds we have. So it's kind of a scary situation, isn't it? We don't know where the alarm is coming in the first place with a busy ICU, with people shouting, patient shouting, a lot of communication happening. So it's an alarming problem. And it also leads to a lot of patient issues, isn't it? It not necessarily be a problem to the doctors. It also causes lack of sleep, delirium. So we are looking at non-pharmacological treatment, which we have discussed in detail while I have discussed with weaning. I'll just leave it at that. It is said that almost many studies say that in a busy tertiary care ICU, we get about 350 alarms per day per patient. In a less sicker group, it may be around 150 alarms. So this is what happens. What happens with this kind of a environment obviously is we go into an alarm desensitization and fatigue. Ultimately, it leads to risk to the patient. So this is what we don't want. But still, it is easy to say that we don't want, but we don't have the technology. In most of the Indian ICUs, there are some innovations. I'll show you what the community and the industry is looking at. But right now, this is an issue. We can say that we want to go and attend every alarm, but look at these scenarios, what I have presented. The number of ICUs per number of equipment with alarms per patient, in an issue, with communication, there is an issue. So this has to be also addressed. So this is the panel of alarms on a ventilator. I'm sure, take my words, none of us set alarms on a ventilator. This I'm saying with experience and having taught mechanical ventilation for years. I've seen most of the ventilators, people don't even, many of you probably have not even opened the screen also. But I urge you after this session, always set your alarms, That is how you identify a problem and then troubleshoot a problem. Few small things, as one question was, normally by default, if you press or if you switch on a ventilator, it goes to 15 to 20% of the normal default value. See, in a ARDS patient, we know between 4 to 8 ml is too much. In a severe ARDS, we don't ventilate at 8 ml. If the alarm sets at 20%, 15% above 800, it doesn't really tell us the problem and there is a problem. So this is not for every sick patient, it doesn't work. But as a default, if at all, if you don't set up also, let it be some amount of safety. The companies have made like this. That doesn't give you any safety to the patient. You have to realize this. As I've given an example of ARDS, in a severe ARDS, you may be ventilating at 5 and the alarm is at 10% above 8 ml, probably a low tidal volume alarm may be beeping all the time. So you have to be patient specific. That is the point. And there is one more setting called auto alarm setting. This is how this works is, it sees for a minute what is the patient's normal parameters. From that parameters, it keeps 10 to 15%. This is an innovation. But this also may not be very good. It is always better you manually set looking at your patient. See on this panel, there are a lot of problems and some things you have to notice. The pressure alarm is always a max of 45 to 50 or 55 in some ventilators is there. There is a pressure relief valve, also called as pressure safety valve. Once the pressure goes beyond 50, the ventilator doesn't give the volume to the lung. It opens up and the air escapes and it says high pressure alarm. So what you have to realize is, if you are ventilating an asthmatic, probably if the pressure touches 50, the volume doesn't go to the lung. It goes out. So the patient doesn't get the ventilation. So you have to be cognizant. I've seen patients changing. I've seen a lot of junior doctors saying that this ventilator doesn't work. They'll bring one more ventilator, connect, same problem. They'll say, once in the morning, if you go, they'll say, sir, three ventilators are not working. Probably this was set at 30 and default setting would be around 35 or 34 because they are 10 to 15% and the pressure alarm touches and the safety valve opens and there is no tidal volume going in. So this is something you have to remember. This may be at times, especially in a severe obstruction, the pressure relief valve doesn't allow volume to go into the lung. This is a safety measure, but it can also trouble you. At 50, if it starts hitting, then we can't ventilate. We have to ambu the patient. But generally, if you set a value of 30 and the default setting is around 30, 35, 40, if it touches 40, the pressure relief valve or safety valve opens. So this can be altered to increase the ventilation or to keep the ventilation going into the alveoli. Look, some of the here, see the expiratory tidal volume is off. Then high respiratory rate. This I call it as in a car we call it as a cruise mode. No, this you can call it as a sleep mode for the nurses and doctors who are doing the night duties, isn't it? When you put the alarms like this, rate, these are the two troublesome alarms. If you ask me, these are the expiratory minute volume and the respiratory rate is two things that generally trouble us. So this has to be never put off limits or put it off so that you can sleep. This is a sleep mode. Look, one more here, peak pressure slow. Any leak, it doesn't tell you. There is no safety. If you set alarms like this, there is no safety. This is manually set. This is worse than going for a default setting. You have gone into a sleep mode. And as I've said, nobody sets alarms on a ventilator. This is a fact. I'm not putting it to exaggerate. I'm sure most of you would agree with me Rarely we set alarms on a ventilator. Whenever we set an alarm, it will always be to switch it off so that we go into a sleep mode. And as I've said, these are the two troublesome alarms on a pressure support ventilation. We have a case scenario how to deal with this. Dr. Saneesh will be looking into it in the end of the session. So the bottom line is there is a default setting. It's much better, but never do like this. Don't switch off the ventilators, the alarms. And the third thing is there is a pressure relief valve or a safety valve which generally sets 10 centimeters above what you set. If you set a pressure of 30, at 40 will be the pressure relief safety. So that is something you have to consider in a severe spasm or a block situation where the pressure relief valve may open up and ventilation doesn't occur. All alarms are equipped with a visual alarm with a message. This alone wouldn't do because sometimes distance matters, isn't it? You will be very away. So there is an audible alarm. The WHO says that it is to be around 35 decibels in the daytime and 30 decibels in the night. This is the standard WHO recommendation for the audible alarms. And there is something called a silence button for 2 minutes. I would say this is the most nurse friendly or respiratory therapy friendly button on a ventilator because this is the most used one. I've seen this. So any respiratory therapist hearing, always remember this should be the last thing you do. The alarms should stop once the problem is started out. Otherwise, if not you, somebody will pick it up. Never ever silence the alarm. The alarm types are immediate life-threatening, something where the ventilator goes into electrical power failure, no gas delivery, electronic circuit failure or a turbine failure. This we call it as immediately life-threatening because no ventilation can occur. And these alarms you can't mute. Obviously, isn't it? It is obvious that the industry would make it in such a way that you can't mute this. And these are also called as input or circuit alarms. Technically, these are input, what you give it to the ventilator to start it working, and the electronic circuit system alarms. But for us, clinically, let us remember these are immediately life-threatening, and potentially life-threatening are high airway pressure, low airway pressure, high tidal volume, high minute inspiratory volume, then low exhaled tidal volume and expiratory minute volume, and asynchronous. This sometimes can be life-threatening, potentially life-threatening. Some are not life-threatening. The problem with alarms is it gives the same audible sound for all three. That's the problem. Some ventilators may have some difference in the quality and quantity of the sound, but it is impossible to pick it up. This oxygen cell calibration is a very common problem I have seen. This should come with the ventilator problem, but it's not life-threatening. Single breath increase, somebody coughs, then by the time you go, the alarm stops. These are non-life-threatening and causes less harm. As I've said, these are also for any DM graduates. They may ask input alarms or control circuit alarms are this, and these are the output alarms, what the ventilator gives, flow related. As I've said, ventilator only produces flow, except the oxygen calibration should be here, but it is not life-threatening, so I put it here. And this keeps a continuous alarm. It's quite irritating at times. And it stops only when you replace the oxygen cell. As I've said, it can be about 150 to 300 alarms per day per patient. And the problem is 95% of them are non-actionable alarms. You don't require to do anything. As I've said, you don't know till you go there. So what happens is it becomes a crying wolf scenario. You go 3 times, 4 times, then you miss an actionable alarm. That's what happens. About 5% are actionable. As I've said, this leads to alarm desensitization and fatigue. This is the problem. So can we do something about this? Can we come to know? There are some innovations, I'll show you. But most of the present day ventilators we work with in India, the kind of scenario, the ICU physical structure is, we don't really know unless we go and see the alarms. So we have to go and see and then decide at the bedside, are they actionable alarms or non-actionable? And as I've said, it is 5% fortunately and 95% are non-actionable alarms. The impact on nurses and respiratory therapists is sometimes it is so distressing. They have a fight or a flight response, sleep disruption, increased heart rate, increased respiratory rate, especially juniors and very senior nurses, increased blood pressure, fatigue, exhaustion, anger, aggression, and pain. They may show it on colleagues, and or else they may go home and show it on their family members. This is something that has to be factored in when we are looking or trying to cut down on impact of fatigue and desensitization. This is important. This also has an impact on the patients also. Sleep disturbances, delirium, negative effect, sleep. If there is no sleep, there is a negative effect on the immune system, slow healing process, increased length of the stay. And if you ask in the end, patients say that they were not satisfied with the ICU care. After having saved his life, probably if you give him a file, he'll say, I'm not happy. This is what happens most of the times. And this is something I've seen all of us have to avoid. You have to be cognizant to the fact that some patient who may be facing death, if somebody casually asks, what happened to the fourth bed patient, the nurse says died yesterday night. See, this should never happen. You remember this. This will have a very, very bad impact on the patient who is facing a life-threatening situation. Even if he's paralyzed, we don't know how much he is able to recollect. So never ever discuss the mortality in the sense that die, death. These are the words you should never use in the ICU. You should never use in the ICU. Remember this. This may look like a silly thing, but I've seen this time and again being done, especially with the senior doctors. So casually they'll come and ask, and this is, then the nurse can't just keep quiet, isn't it? She can't say to the doctor, if this is a bad question. So eventually the answer comes out, and it has a very bad impact on the patient who is facing a life-threatening situation. So how to cut down? What are the reasons for alarm fatigue? If you look at excessive workload, staffing issues, we know in our Indian ICUs, one nurse may be managing 3 to 4 sick patients. So there is the issue how to, she doesn't know. By the end of the shift, she may be so tired, she may be not even be able to appreciate the alarms. 1. 2, poor alarm design and setting. As I said, there is no difference, appreciable difference where we can make the sound, whether it is a actionable alarm or a non-actionable alarm. Then there will be competing priorities, unclear delineation of responsibilities. Even if the nurse goes and picks up and knows there is an alarm, we have not told her what she should do. So you have to have a protocol in the ICU. This alarm is grade 1. So this has to be informed to the duty doctor, grade 2 consultant, something like that. There should be a clear delineation of responsibility, hierarchy. The hierarchy ladder has to be put in place. Then there is no escalation plan. So the same thing, once you identify whom to inform on what she should do, also has to be put in place. And all this leads to desensitization to alarms. Are there any thought or any studies done to improve desensitization or to cut down desensitization and reduce the alarm fatigue? Let us see. So these two are important: timely servicing of equipment and calibration and testing, because many alarms keep ringing because of this. So this can be sorted out, isn't it? If you have a good biomedical engineer, you have to insist that he comes and does this to every ventilator that is free, and he has to test it. And I've seen in places that there will be a sticker say that calibration has been done today and servicing has been done on this date. So you see to it that this is easy to implement. This has to be implemented. Then, as I said, patient-specific appropriate alarm setting should be there. Then effective staff education and training. Clear, actionable alarm information has to be put up, like guidelines or a escalation plan has to be in place. Multidisciplinary team to review and upgrade alarm protocols. And not the last but not the least, you have to go back to the industry and tell some alarms are not required, or see somebody coughs, alarm comes. Can we have an alarm which keeps escalating if somebody coughs thrice in a minute? Something like that has to be told to the manufacturer that this is what we require, because we are the end users, isn't it? We have to give the feedback for them to make the alarm systems better. And I feel we should have alarm management drills once in every week or once in every month, or a nurse can be trained, or a respiratory therapist would be ideal to run the drills for the ICU team once in every month or twice in every month so that the fatigue and desensitization doesn't occur. So points to remember is never ignore an alarm, never mute the alarm, never ever set alarms so high that they're not triggered at all. This is, as I said, sleep mode, like in a car cruise mode, no? This is what generally people do at night. I've seen this happen many times. So it should not happen. Find out for yourself what the alarm is on and check the patient and solve the problem. This is about alarms. So the bottom line is there is an issue. It is easy to say that get desensitized, don't get fatigued, but there is an issue. Alarms have to be sorted out. We have to go back to the manufacturers and be required to sort out. And surprisingly, there are no very high quality studies looking at the alarm pathology and alarm issues. So this also has a neglected, like weaning. This is also neglected. I think the younger generation doctors and critical care specialists can do studies. This is a gray area. A good study will be published in a very high impact journal. You remember this. Weaning and this is easy to do, easy to get ethical clearance and easy to do. So I urge the younger generation doctors to think something about the alarms and the weaning parameters to do studies on mechanical ventilation. As I said, are there any innovations? This is implementation in one European country where the nurse sits outside and starts monitoring. This is a future ICU where the data is sent to a data management department, which is overseen by a consultant, one or two, depending upon the requirement and the load of the hospital. Then the central alarm system puts out an intervention and it sends the intervention to all the nurses, doctors, and the respiratory therapists on duty. This is what the future ICU should look at, and probably with time India also will see ICUs like this. And with artificial intelligence and cloud technology being developed, so the data management center can analyze multiple alarms and put out the interventions much easier. Probably this is what will happen in future. This is just a representation of what is in progress. In many centers have implemented also something like that. In a COVID situations, probably this may look very attractive, isn't it? If you have a center or a hospital like this, management also would become easier. So that is about alarms. So we'll go to troubleshooting now. As I've said, never ever mute an alarm. Uncovering the underlying derangement and correction is the take-home message. I've insisted, I keep insisting, and I hope all of you will take it to your bedside. So when you are troubleshooting, there are only three main components, isn't it? One, patient, two, tubings, three, ventilator, and you should never forget that the troubleshooting is done for patient safety. So it should always start from the patient. If you never do a troubleshooting from the ventilator, it may take 2-3 minutes to reach the patient. And the goal of troubleshooting is patient safety. So it should always start from the patient. And you should never forget that this patient safety or whatever we do, anything, the admission to patient recovery always depends, you remember this, oxygen delivery to your mitochondria. Patient is admitted because it's not happening. Patient is in the ICU because it is not happening. Patient will be safe only when it is happening. So it is a cardiorespiratory function. So whatever we do, what is the impact on the heart? You may have the best of PaO2s in the blood. If it is not pumped to the mitochondria, there is no use, isn't it? So this is the fourth component. These are the three, and that also has to be kept at the back of the mind. So always start the troubleshooting from the patient, and I put it as a time of 5 minutes. I'll come back to that. In a life-threatening hypoxemia, 2-block extubation, this is the cutoff time. The brain hypoxic ischemic time is our cutoff time. This is generally accepted as around 5 minutes, 3 to 5 minutes. So we only have 5 minutes. If the patient, and as I've said, they have a very low physiological result. So troubleshooting is something which requires constant drills, lot of integration of knowledge. And I would urge, when 4 people are there, when there is alarm, in a sick patient, all 4 go to the bedside. Don't neglect the alarm, because 4 hands always saves the patient better than 2 hands, isn't it? So that is something you have to remember. My point is, if there is a life-threatening hypoxemia, which is the alarm and the problem is leading to a life-threatening hypoxemia, our cutoff time is brain hypoxic ischemic time, that is about 5 minutes. You remember that. Then how do you, risk assessment for troubleshooting is important. So now whenever you see, you think, one is life-threatening hypoxemia is there or not. It is, as I've said, is unstable hemodynamics, SCVO2 lactate of more than 2, SCCO2 of less than 60, a PCO2 gap. This is very easy to do. You do a venous oxygen saturation, you look at the carbon dioxide, you look at the arterial carbon dioxide, the gap should be less than 6. If it is more than 6, there is some issue. That is very easy to do, very underutilized parameter. With time, Anoop and Saneesh and me, we will discuss, and probably we'll have a class on PCO2 gap once we finish the mechanical ventilation module, and non-actionable alarm. So when you go, the first thing you have to look at, is it life-threatening hypoxemia, no life-threatening hypoxemia, or a non-actionable alarm. Then added to that, we have an unstable hemodynamics and how sick is the patient. He may be on 100% FiO2, a PEEP of 16. So can we ambu this guy? Very difficult, isn't it? So this is something you have to, this is the risk assessment of troubleshooting. I'll show you 2-3 examples. You see how troubleshooting would be different for different patients. As I've said, DO, the delivery of oxygen is why the problem with this is why the patient is in the ICU, will be in the ICU. Once you correct this, patient becomes all right. Most of them get out of the ICU. We will probably do one class on DO2, the delivery of oxygen and the requirement. Is it enough, and how to assess at the bedside. As I've said, if there is a life-threatening hypoxemia, low reserve, you have to work like Usain Bolt. All of you should become Usain Bolts at that point of time. That is what you have to understand. So risk assessment for troubleshooting is always look for hypoxemia, desaturation level. See 98. If somebody is 90, see this may be much easier to, you have more time troubleshooting this guy rather than troubleshooting this guy, isn't it? This is the first thing you have to look at. This is risk assessment for troubleshooting. 2, patient's condition. Can he be managed with a mask and bagging? As I've said, sometimes it is a ARDS guy with 16 PEEP and 100% FiO2. If you remove and try to ambu, there may be a precipitous fall with your SpO2. So this is something you have to factor in before you go, because you know the patient. If it is an ARDS patient, you probably know the reserve is low. So 4 of you should go. OP poison and pressure support. You know, even if the tube has come out, you can remove it, do a rapid sequence intubation, re-intubate. But can you do that to the ARDS guy? It's much difficult, isn't it? So second thing is, look at the patient's physiological reserve. See, I'll show you an example. OP poisoning, day 5, weaning, stable, AVG, BP, X-ray, normal. See, these are the settings. The saturation is 88. It was 98, has come down to 88. There is a tube block. You analyze. I will tell you how to analyze. You have analyzed. It's much easier to exchange the tube, isn't it? Low risk, low endotracheal exchange risk. So this is a different scenario. Look at this now. Severe ARDS, PF ratio is less than 100 and 2 inotropes. He's on 80%, 5 ml of tidal volume, PEEP of 16, plateau of 31. He has a block. It's a different scenario, isn't it? Look at the AVG. Acidotic, hypoxic, hypercarbic, lactate is more. So this guy is sick. There is no reserve. So if you want to do a tube exchange, it is better a senior guy is there and who has the experience, and all the hands are on the deck. All the hands are on the deck, because this is a guy who's going to die if you don't do the troubleshooting well. So both cases are not same. So that is what I'm trying you to analyze, how to, by the time you go to the patient, this should all run through your mind. What is the life? First is life threatening. What is the hypoxemia level? Next is physiological reserve. How sick is the patient? Can he tolerate some amount of procedures which I can do, like tube exchange, or take more time to analyze the situation? These are the things that you have to analyze. Third is, as I've said, hemodynamics. So look at this. This is what is the whole situation we are looking at. Is this DO2 reaching here? Is the question. See, look here. A BP of 90/40 and 2 inotropes, lactate is 4, SCVO2 is 61%. This guy has no reserve. His blood doesn't have the enough content to satisfy the mitochondria. On that, if you add up another stress, this guy may collapse. Look at this guy, BP 130/80, lactate is normal, SCVO2, OP poison guy, ARDS guy. So this guy is, he will tolerate hypoxemia or a low blood pressure for some time. This guy doesn't. So you have to factor in three things. One is what is the physiological reserve, one is how is the lung, and how is the hemodynamics, and what is the amount of desaturation that is occurring. So to summarize, before you go to the patient, you put the patient into three situations. Now we have left out the non-actionable alarms. We have left out only the alarm. There is something you have to do. Now you have to categorize the patient. Risk assessment for troubleshooting. 3 categories. 1, life-threatening hypoxemia, low physiological reserve, sick lungs, high ventilatory settings, unstable hemodynamics, and DO2 is not equal to VO2. The delivery and requirement are not equal. I have said you can look at your lactates. You can look at your base deficits also. They say it's a poor man's lactate. Not very accurate, but it gives, if you don't have a lactate, look at your base deficit. If base deficit is low, they say it tends to show you that DO2 is not equal to VO2. This is high risk category. That's why I put it in red. Next is life-threatening hypoxemia, good physiological reserve. Stable hemodynamics and DO2 is satisfying the requirement. This has more time. So, and the third one is no hypoxemia. High respiratory rate, high increased expiratory volume. These are the 2 alarms in a spontaneously breathing patient which calls you repeatedly. And we have a case scenario. Dr. Saneesh will tell you how to handle this. And the third one is asynchronous. Asynchronous. These are not immediately life-threatening, but this may, if not handled well, may lead to autopsy, then diaphragmatic injury, things like that. In a long run, this may affect, but this may not require very immediate, like kind of a Hussein Bolt kind of a response here. But this also has to be addressed. This may lead to long-term effects. Like asynchronous, lot of PEEP, auto PEEP is there. Then there's a compressed diaphragm. Then your diaphragm becomes non-functional. I have shown you the diaphragm, what is diaphragm safe ventilation. So these things happen in the third category. So don't neglect this also, but you have time to analyze and discuss and then separate the problem. But these 2 are something which you have to immediately attend. Is this clear? The risk assessment is very important. By the time you go to the patient, this should run through your mind. This is what I'm urging you to remember. So only practiced and familiar skills work in a crisis, isn't it? If you suddenly go and see that there is something crisis and don't know what to do, it doesn't work. And the team should know role playing. Who should be intubating? Who should be loading the drugs? Who should be calling the senior? Or who should be bringing a defibrillator? See, the whole role playing should be fixed in an ICU. There should be a very clear in every shift. There should be a very categorical fixation of who plays what in a alarm drill. You can do. I urge the senior most nurse or a respiratory therapist to do this. They should be the leaders who should be conducting these drills. And you can always consult with the consultants and take the approval and make a workable drill for your ICU in particular. And this is very important. And the third thing is all this should be handy. So the drill should also include where they are. And suddenly if you ask a nurse, go get a scope, she'll bring a scope. And invariably the light doesn't work in a crisis. Take my words. I've seen this happen time and again. It happens that way. So I think this difficult airway drill, I think Dr. Saneesh would do in the course of, he would look at these aspects, why checklists and drills are very important, because this is what saves the life. And only practiced and familiar skills work in a crisis. Remember that. And third is integration of knowledge. Knowledge is this, when you go, all this you should know. Hypoxemia, what is the ETCO2, what is the ventilator doing, and you should have a baseline ultrasound skill. So this will tell you where the problem is. The more and more you know this, the better you will identify in a shorter duration, and the patient will be made to survive. I said in a very life-threatening hypoxemia, we just have 5 minutes. We just have 5 minutes. So this knowledge is important. So let us try to analyze how much we know, and or else most of it we have already learned. We'll just recap so that when we go into the scenarios, you already know, or people who are attending for the first time. Let me just take you through what are important to know on the ETCO2 front, on the ventilator front, ventilator graphics, especially ventilator graphics, and the ultrasound and chest X-ray. ABG also is important, but ABG, chest X-ray, and ultrasound cannot be done in the first 5 minutes. So any life-threatening hypoxemia, you have to do with ventilator graphics, ETCO2, and pulse oximetry. More than 5 minutes, as I said, life-threatening, good physiological reserve, probably you can get a pulse oximetry, you can get a ultrasound machine, go for X-ray, or get a ABG. That also you have to remember. So we'll bridge the gap now. We'll bridge the gap. The eye sees what the mind knows, isn't it? So we'll try to learn all this very briefly, what is required for only troubleshooting. I'll not go, each one will, graphics we have dealt very, very clearly. I think Saneesh would agree that ultrasound also has been done. I saw the ultrasound module also. Chest X-ray also Saneesh has done himself. So this is covered. I think Saneesh, ETCO2 module has to be taught to the students. Is very, very, very important, especially for anesthesiologists and critical care specialists. Anesthesiologists are good at ETCO2. I've seen the consultants in critical care don't give a lot of importance to ETCO2. This has to be drilled, that it's a very good parameter. We will discuss and we'll come back with a module on that also. And clinical, see the chest, hear the chest. Don't forget that. See the chest and hear the chest. So as I've said, for 5 minutes only, one is clinical examination. Always remember this: see the chest, hear the chest. 2 is ventilator parameters. As I've said, you can look at the tidal volumes, respiratory rates, and also the graphics. Graphics gives a lot of information, isn't it? If P plat is high and PEEP also is high, you definitely know it's a compliance issue. If P plat is high and PEEP is high and P plat is low, then the trans airway pressure is very high. You know it's a respiratory problem or a airway problem, isn't it? This we have taught. So you don't require to auscultate also. Once you see that, you will generally know, oh, this is some spasm is going on or some block is there. This is what we have been insisting that you learn. And there is a module we have already put up. Okay, somebody who has not attended can go back and learn. And 3 is ETCO2 and SpO2. In 5 minutes, this is what you have to do and handle the patient with only these parameters, because this 4th module or the 4th set of investigations can't be done in 5 minutes, isn't it? If somebody is, or if the ultrasound is connected, probably you can put in a probe. Otherwise, you have to do with this. We have discussed this and we know the pulse oximetry. Then we will spend some time looking at ETCO2, some 4 slides, and then we'll go for troubleshooting. So seeing the chest expansion, the most important sign, if you ask me, the most important sign is just open up the gown and see the chest. Don't see with the chest gown, you can't see, you can't make out. So just see. Most of the times it gives you very good information. Any unilateral depression or a bulge, pneumothorax, there may be a bulge, there is a collapse, it will be slightly lower than the other chest. You can, and tracheal tube marking at the lip. Suddenly it may be out. This gives a clue. This is something the eye, within 10-20 seconds, this should be done. You should practice it every day when you go look at where the plaster is stuck. And this is a standard teaching, not necessarily true for all patients, but most of it works. We have seen this. This is what we generally keep in the ICU. And here the chest, V's, reduced or absent breath sounds, give some information where the problem is. So this is easy to do. This just requires about less than 30 seconds. Your eye should be so well versed looking at this. This should be done by the time you go to the head and side to put an ambu bag. This should be done. This is what your drill and training does to you. So ventilator parameters, as I have said, this is easy, isn't it? You remember this. This is trans airway pressure, difference between peak inspiratory pressure and plateau. This comes with an inspiratory hold of 1 to 2 seconds, and obviously this can be done only on a volume controlled mode in a patient who is passive. In a pressure controlled mode, PC with PEEP is the P plat. This you have to remember. We have discussed this in very much in detail. So now going into troubleshooting from the ventilator point of view, always relate your peak inspiratory pressure to your tidal volume. You should always relate this without, as I said, the purpose of mechanical ventilation is to put a volume into the lung. When you put a volume into a closed space, alveoli is a closed space. Once you put, pressure increases. So if you relate PIP to volume, it makes you to analyze where the problem is. This is not always true, but most of the times it is true. When the PIP goes up and the tidal volume delivered to the lung is less, the problem tends to be in the airways or tubes. When the pressure goes up and there is no volume going into the alveoli, probably there is a block above this level. There is a block somewhere here. And if the PIP goes up and there is a decent amount of tidal volume being delivered in alveoli, probably this is not a risky situation. And the problem lies in the compliance issue. The lung has become little stiff. That's why the pressure has come. This is not always true, but it works in most of the situations. Remember this. And as I've said, these are the most troublesome alarms that you get on a ventilator. And this is because of the increased respiratory drive. You should always consider these factors. There may be an increased hypoxia, hypercarbia, acidosis, fever, pain, anxiety. And these three things, fever, pain, and anxiety, are very easy to control. Very easy. Away from the ventilator, you can control. So this has to be factored in whenever respiratory rate and expiratory minute volume goes up. As I've said, there is a pressure relief valve. Always see asthmatic patient. I have set a pressure of 30 and the PIP will be 10 centimeters. The pressure relief valve will open 10 centimeters above the peak inspiratory pressure. The peak inspiratory pressure is now 30 and it is set at 40. You put a patient, asthmatic patient, intubated, severe bronchospasm, and his PIP goes up to 45. Now what it does is, it touches 40, it opens up. So no tidal volume gets into the patient, or very low tidal volume goes, and you also get a low VT or VE alarm. High pressure with low VT alarm sometimes come. I have seen patients, the doctors, junior doctors saying that the ventilator is not working. Same problem. What you should do is not change the ventilator. You increase the Pmax setting to 50, because we know now that the pressure is dissipated in the airways. And if you check a plateau pressure will be 20. The PIP pressure will be the 45, 50, but your plateau will be 20. The trans airway pressure will be more. So at that situation, it is not very harmful to the alveoli. Till you medically manage the patient, probably this setting has to be made. So you remember this, there is a pressure relief valve, always 10 centimeters above the PIP will be a default setting. It starts opening up. It doesn't allow the air to go. It's a safety valve. And these are the graphs. What kind of a scalar is this? What is the pathology here? Isn't it? This may be causing him to go into fighting with the ventilator, or its pressure may be started dropping because there is autopy. So this is easy to pick up. Flow versus time scalar, very easy to pick up. These things, secretions are there. You don't have to, alarm is coming, high pressure alarm, just go and suck. You don't have to auscultate. It is very accurate. A study proved that it's much accurate than your auscultation. And if you see something like this and a volume versus time scalar, this is a leak, isn't it? We know, we have learned this. If somebody has not attended that session, it is the recorded graphic session. You can go and look into this. And this may be happening. You don't have to auscultate. You don't have to do. Once you see this, you know some leak is occurring. And most of the times the leak will be in the circuit or in the endotracheal tube cuff. And this is compliance issue. This is resistance issue. And if there is a autopy, there will be missed breaths. And always remember, when you're trying to look at the asynchrony in a pressure support ventilation, you should always look at the expiratory tracings, even in the pressure expiratory tracing or in the flow versus time scalar also. Expiratory tracings always give you a clue that something is wrong. You see which is not smooth, there is a missed breath. It's always expiratory tracings. Remember this. We'll do a session on patient ventilator interaction in the subsequent days to come. I'll teach you, but this is something to remember. And as I've said, if it's a volume ventilation, pressure changes, and if it's a pressure ventilation, volume changes. This we have discussed already. Next 2-3 slides is about EtCO2. This is important. It's very easy. It is not very, very difficult. And you remember this, SpO2 lags behind EtCO2. EtCO2 is the first parameter. If somebody gives you a choice, which parameter you want, you always choose a EtCO2, not the SpO2 in a troubleshooting. Because this is what gives you a lot of information. And the graph looks like this. This is when there is no carbon dioxide. This is the inspiratory phase. Once the patient starts breathing, where does the air come from? Initially, from the tubes. There is no carbon dioxide. Slowly, as it picks up and reaches the alveoli start emptying. We get the alveolar phase. And this is the alpha angle. This is the beta angle. And the peak of it. Why this goes up is because the alveoli of different constants. See, this alveoli is stiff and this is not stiff. So this takes more time to empty because there is also a spasm. So gradually, when everything empties, the value goes up, and we at the end of it, we take it as EtCO2, and this is the inspiratory phase. This is the inspiratory, expiratory, and inspiratory phase. So this is the upswing alveolar phase and downswing, whatever you call. You have to think air is coming from here in this phase, and the value is going up. This is alveolar plateau, and this is the downswing when the inspiration starts. And another thing is, this contributes to the anatomical dead space, and this contributes to the alveolar dead space. And this is what the PaCO2 gives you. PaCO2 gives you this value, and EtCO2 gives this value. There is a difference of around 4 to 6. This is normal. If the gap increases, you can always know that the dead space or a shunt has increased. This also can be made out by looking at your ABG and your EtCO2 reading. I have a slide. I will explain it to you in the subsequent slide. And this contributes to the alveolar ventilation. As I have said in COPD ventilation, this is important. And another thing, always remember, look at the volume of the graph. If the volume of the graph changes, there is a problem. When the shape of the graph changes, there is a problem. When the volume of the graph changes, there is a problem. Remember these two. I'll show you how to analyze the EtCO2 graph. See, carbon dioxide is always more important in a troubleshooting because it tells you what is the ventilation status, what is the circulation status, because carbon dioxide is brought back from the microcapillaries or the microcirculation. So any problem here or here, the carbon dioxide changes, then circulation, it has to be pumped in and oxygen goes in. So metabolism. So all three factors are factored in your EtCO2 graph. So you can, if you are good at analyzing EtCO2 graph, you can look at what are the problems with ventilation, circulation, and metabolism. Both the ventilation problems are shunt or a dead space. So EtCO2 tells all three. So these are the only three I would urge you to remember. See, one is obstructed expiratory flow. See, there is a difference in the shape of the curve and also the volume. In both the curves, you see here, both the curves, there is a difference in both the shape and the volume, And second thing is, when there is obstructed flow, it takes a longer time to reach the peak. And with time, this value increases, EtCO2 goes up. Here, the leak volume is lost, so EtCO2 falls. And the curve also is different. This looks like a shark fin appearance. This is called shark fin appearance, isn't it? It looks like that. So whenever there is a slow and a delayed emptying, this is how you see. Whenever you see a EtCO2 with a shape like this, you should always know that there is an obstructed expiratory flow. This may be because of bronchospasm or a kinking of the circuit or a tube block. We don't know, but this is what it implies. Leak. It may be at the catheter mount, it may be at the humidifier, or it may be the cuff. We don't know. But the volume is less, shape is different, and it is EtCO2 is less. And when there is a endotracheal tube slippage, the curves, there is no graph. This is a situation which requires very, very immediate action. These are the only three things you have to remember in EtCO2 for troubleshooting. There are other things like bronchospasm. I said it could be because of, this is a shark fin appearance, maybe because of all these three reasons. And there is, when we were learning EtCO2, we always thought it could not be done in a spontaneously breathing patient. But there are technologies that have come, especially in a COVID situation, if your hospitals are willing to pay, probably go with this kind of a technology where you can look at ETCO2 in a spontaneously breathing patient. Leaks, as I said, leaks can be because the cuff is at the vocal cord level, or it has slipped out, or there is a catheter mount which has opened up, and this accidental extubation or a complete block will have a graph like this. This requires immediate action. And esophageal intubation, if at all, if you are looking, see, you will see a graph like this. Probably you have put some gas into the tummy, it is coming within 2 to 3 volume, it becomes flat in esophageal intubation. You remember that. This is about cardiac output. See, once the cardiac output starts coming down, look at the ETCO2, it is also coming down. This is from capnography.com. This is one website. I urge you all to go and see. It is well written by Indian American. It's very well written, and a lot of graphs like this are there for you to learn. So as the ETCO2 comes down, the cardiac output comes down, the ETCO2 also comes down, obviously, because the volume is not bringing, the blood is not being brought to the lung from the periphery. So obviously, the amount of ETCO, the PaCO2 becomes less, so obviously ETCO2 also becomes less. And this is what shows you if there is a pulmonary embolism. As I've said, the gap between PaCO2 and ETCO2 will be more than 12. Ultrasound, very easy to learn. There has been a module. I'll just not spend much time, all of you, just to make you know this is interstitial edema. When all the B lines are together, we call it as pulmonary edema. This is a barcode sign or a lung point sign, which is pathognomic of a pneumothorax. This is very easy to do, but sometimes difficult if the pneumothorax is very small, but it can be learned and done. And this is pleural effusion. This is pleural effusion with collapse consolidation. And again, this is different collapse consolidations. And this is trachea also. You can look at the trachea. When two tubes are together in the same screen, we call it as double tube sign. This can be used even when you do a percutaneous tracheostomy. Percutaneous tracheostomy, it is sometimes helpful. X-rays, this is pneumothorax, pulmonary edema, ARDS, and how to place. If you have an X-ray, we generally say carinas can be easily made out about 2 to 5 centimeters above the carina is the ideal place to put in the tube. That also you can make out if you have an X-ray, and sometimes when you do a CT scan, it also gives a lot of information. Now we will go into troubleshooting, just about 5-6 slides. In another 10 minutes I'll finish. You remember this, the most important equipment in the ICU for troubleshooting or for saving a patient is your ambu bag. And how you keep your ambu bag is important. Every patient has to be having a ambu bag. If you don't have fancy things like this, if you have a hook, you can put it on a hook. I've seen it being put on the floor, on the bed, very close to the patient, lot of secretions, then again connect, ambu, suction, throw. This should not happen. If you don't have all these fancy gadgets, put it in a Ziploc cover. Both the ambu bag and your nebulization kit can be kept in a Ziploc cover, which can be ethylene oxide sterilized. It's very easy. We used to do in the hospital, and it is better if you keep it connected to the flow meter, because that time also you may save. But you can make something like a porcelain box like this with a small hole here where the tube is already connected to the flow meter. This doesn't cost much. This may cost you about 400-500 rupees. It look more elegant. It can be put very close to the suction or the oxygen points. So think about this. Now the systematic approach. Now we have learned how to triage the patient. What is the information required? Let us see how to do it on the patient now. So once an alarm comes, you go there. Life-threatening hypoxemia, unstable patient, no life-threatening hypoxemia, non-actionable alarm. Once you make the decision, then if this is the situation, you have to become a Usain Bolt. I have told you again, and this is how you triage the patient. Now you go to any patient. Sometimes the alarm comes. I urge always increase the FiO2 to 100% to all patients, whatever the alarm, because it may give you time when the crunch comes. So always make FiO2 100% if it is looking like a life-threatening hypoxemia. One. Sometimes it is very apparent. There will be a disconnection or the ET tube will be very much out. So it becomes very apparent. Many times it is apparent, so there is no problem. Once you see a ETCO2 like this and the tube is outside, so what is there to see now? You just have to take a tube, go for a rapid sequence intubation and intubate. So it will be apparent at times, or if there is a catheter mount which is disconnected, you just have to connect. So this, sometimes it is apparent, it can be done, no issue. If it is not apparent, how to go about? Now that is a systematic approach we have to learn. One is observe the chest, observe the patient, observe the chest movement. Now to disconnect the ventilator or ambu with the bag, you have to make a decision, isn't it? This depends upon the amount of hypoxia or hypoxemia, and there is no relief. You can't make out anything. The alarm is coming, the saturation is dropping. So first thing you do is you disconnect the ventilator, put an ambu bag and start ambuing, connected to the oxygen, 15 liters. If the SpO2 improves, then you know the problem lies with the ventilator. The chest starts moving. These are the two things you can obviously see when you're ambuing. Look at the chest. If the chest starts moving, you know that SpO2 is improving. There is a ventilator or anything away from the whole circuit, and the problems outside the connection of the ambu bag and below is not the problem. That much decision you can make out. Next, if the SpO2 doesn't improve and the chest doesn't move, then you get more information, isn't it? Then the problem lies below the ambu bag. What are the things below the ambu bag? One is the endotracheal tube, some airways, and the chest, lung alveoli and the chest wall, isn't it? These are the problems you tend to analyze. Once you put the ambu bag, SpO2 starts improving. The problem lies from the circuit which you have disconnected and the ventilator. And if the SpO2 doesn't improve, then the problem lies below the ambu bag. You remember that airways and the alveoli and also the chest wall. These are the areas of problem now, because this is what is below the ambu bag. If air leak is heard or gurgling sound is heard, or once you put a scope and you see the ET tube is around the vocal cord, you can reposition or re-intubate. See, now you look at the ETCO2. What is happening now? What is happening? See, I have heard something, but I don't want to put a scope. It may take time. Just if I look at my ETCO2, the volume is less and the ETCO2 has fallen. This looks like a leak. See, this is what you have to analyze. We have learned this, isn't it? So when you go to the patient, disconnect the ventilator, ambu. If ambu starts working, the problem is with whatever the circuit you have disconnected and the ventilator. If you are not able to ambu, SpO2 starts dropping, then the problem is below your ambu bag. The components below your ambu bag are contributing to the pathology. Then look at your ETCO2 and your ventilator graphics. They give the idea. See, ventilator graphics gives the idea there is a leak. Then ETCO2 gives the idea there is a leak. Then you have to find out where the leak is and set right. Probably the leak will be in the cuff, isn't it? Or the endotracheal tube is mispositioned. There are only two things where the leak comes from. So it becomes obvious. So you have to analyze like that. That is the systematic approach you have to take. Ambu bag is tight to squeeze, but some air is going to go into the lung, chest is moving, chest is noticeable. This is a situation which tells you that you don't require to replace the tube immediately. I would say patient is much safer on a ventilator than on an ambu. You remember that, because you are giving a controlled ventilation. Because if you see a nurse ambuing, as the saturation starts dropping to the patient, she gets excited. She'll pump in 1.5 liters into the lung. She'll start squeezing it with all her might. This is what happens. So if some air goes in, it is always better to not go with a tube exchange. You can go with a suction. Next option is suction. If it is easy pass, you know the problem is in the airways, not in the tube. So this is how you analyze. Now you do a plateau pressure and a difference. If it is more, then you know it is a bronchospasm. So one is disconnection of the ventilator, going with the ambu. Ambu results are positive. The problem is with the circuit and the ventilator. If ambu is difficult to or not at all, you are able to ventilate, the problem is beneath it. If there is some movement, then go for a suction. If there is no movement at all, there is no point in trying to squeeze. You probably have to go for a tube replacement. So bronchospasm is different to look at you see shark fin appearance, very typical. And these are some of the problems. And leak, as I've shown, these are some of the problems. And respiratory issues, I have already shown you. These are all kind of integration now. Now you see this, you know it is atopy. You in a COPD patient, probably you will increase the, and if it's in a pressure support ventilation, you will try to increase the expiratory time. How do you increase the expiratory time? Increase the expiratory time trigger sensitivity from 25% to 40%, or increase the peak flow. So that is what you have to do. Look at the graphics, look at the ultrasound, look at the ventilator graphics, make a decision where the pathology is and do the appropriate ventilatory changes. There is something, this is very commonly put out. I don't think you have to, somebody may ask in the exam, that's why I made this slide. You don't require to really remember this. It's called dopes to the pathology and dots for the treatment. So displacement, obstruction, pneumothorax, equipment and tubing, stacked breaths. So disconnect, connect oxygen, tube check, change the ventilatory settings, then sonograph or supervise with this. This is what we have discussed, isn't it? This is a kind of a summary of what we have discussed. I'll just leave it at that. We'll not go into this asynchrony part. It is little tough to comprehend. We'll do it some other time. So take home messages says, respect your alarms, don't mute or do not mute, correct the problem, have an alarm fatigue correction program, have a systemic approach for troubleshooting, practice alarm drills. Only 4 components to consider, remember this. Patient, tubing, ventilator and heart. Thank you. We'll do one asynchrony class in patient ventilator asynchrony. It's a little tough to comprehend. If there is some trigger asynchrony, the asynchronies, always remember more than 50 to 60% of asynchronies are caused by trigger setting. And I said trigger setting has to be 1 to 2, whether it is flow or pressure. And good flow setting, especially flow is fixed in a volume controlled ventilation. Flow is better in a pressure controlled ventilation. So when there is a flow asynchrony, always try to put the patient on a pressure limited modes or pressure regulated modes, patient becomes better. This is something, this would correct almost 60% of your asynchronies. These 2 points, if you know, this will correct 60% of your asynchronies. Thank you. Any questions I'll take? Then Dr. Anoop, Dr. Saneesh will do some 6 case scenarios today, 5 or 6. Any questions?
No, regarding the CO2 gap, a few persons were asking, sir. I think you can just explain once again.
The CO2 gap is a difference between venous and arterial CO2. So you do a SCVO2 ABG, you will get a venous PaCO2. Do a arterial ABG, you will get a arterial PaCO2. The difference should be less than 6. If it is more than 6, there is a problem between your delivery of oxygen is not proportionate to your delivery of your requirement. DO2 is not sufficient for your VO2. That is your assessment. Why that is better than your SCV, your lactate or anything oxygen, looking at oxygen parameters is because carbon dioxide has a diffusion coefficient which is 20 times more. Even if the microemboli are there in your microcirculation, it still is possible that the carbon dioxide comes out. If the carbon dioxide production is more and your oxygen is not able to supply and manage the gap, then you know something is going wrong. And the whole idea, as I have said, is to have a appropriate DO2 to your mitochondria. Patient is in the ICU because it is not there. Patient will be in the ICU because it was not happening. Once he gains the strength to balance the DO2 to VO2, he'll be out of the ICU. This is something you have to remember. That's why it's important. We will do a class. Once the module gets done, if Anoop and Saneesh give me permission, I'll do a gap, PCO2 gap. That's something I'm very interested, and I have already made the slides also for that, for some other presentation. So that will be an easy class for me.
No, you
One
don't
thing,
need any permission from us, sir, because this is your platform. You can decide and schedule
no, no,
according to your convenience.
I was just joking. I know that. I know that this is a platform where it is our three of us had decided this, isn't it? Long time, but Corona made us do it. Okay, that is about PCO2. I'll come back in the course of next month or two once the ventilation modules are through. Any more questions? Or else we'll go for cases. We'll go for cases.
I think we'll discuss along with the cases. Any doubts and all,
Any
we'll
doubts
discuss
there,
along.
we'll troubleshoot like that.
Okay.
Yeah.
And if you want to add something before?
So we'll do the case scenarios, and I think we'll discuss during.
Okay. So initially, I'll quickly go through the pre-test answers. I think the answers must be obvious. My screen is visible?
Yeah.
It's visible.
Okay. So the first question was a 50-year-old patient on volume control mode, ARDS, passive. Ventilator gives high pressure alarm. What do you do? So obviously the message is clear. I don't think there should be any scope for any doubt after listening to Chandrasekhar sir. So it's all about identifying and managing the problem. How to make it in a streamlined manner is what we have to practice by mock drills and creating protocols and role assignments and all. Okay. So second thing, high and low alarm limit default setting on a ventilator. We already mentioned it's 10 to 15% above and below, plus minus the normal values for that particular case, particular scenario. Okay, there is no universal benchmarks. It all depends on the patient's condition, and gradually evolving settings will be there. Alarm fatigue management include, which should not include, that is setting alarm limits 50% plus or minus the present values or normal values and go to sleep mode is not allowed. So you should have effective staff education and training. Calibration and testing of ventilators should be done before use. A multidisciplinary team should review and upgrade alarm protocols. Okay, that's also been discussed. High pressure alarm can be triggered by all of the following conditions, except I think there is no confusion among the attendees even before the session and after the lecture. It's no doubt scenario. Question number 5, patient on ventilator, high pressure alarm gives hypoxic, saturating 77%. What do you do to include all the following except silencing alarm? That is one bad habit we have to stop after learning to do the troubleshooting and be familiarizing with the alarms. Okay, can I have anybody volunteering for this? So basically the risk assessment, this is the summary slide. First, we have to make sure whether we are standing on a life-threatening hypoxemic scenario or no life-threatening hypoxemia. Again, we have to consider whether we are dealing with an unstable hemodynamics. These are the indicators: SCVO2 less than 60%, a high lactate above 2, PCO2 gap more than 6. And then non-actionable alarms are there, and some alarms we cannot silence also. Like if you forget to connect the oxygen or air supply, the ventilator will keep giving alarm. You cannot silence the alarm. And some situations will have enough time to troubleshoot, but general rule is 5 minutes is the cutoff time because brain won't wait more than 3 to 5 minutes. So decision algorithm, life-threatening hypoxemia, unstable hemodynamic, evaluate whether the patient is sick, whether the patient is on high ventilator settings, high FiO2 or 100% and high PEEP. There is less option for you to play around with the ambu bag or airway maneuvers. So you should have the best person tackling the airway, and you should have all the resources mobilized almost within no time, because we don't have much time. So the issue is basically we are dealing with the DO2, oxygen delivery to cell mitochondria to sustain life. It's a cardiopulmonary function. So whenever that is compromised, we have to be on our toes and do the best. So 5 minutes is our cutoff. And be like Usain Bolt. To be like Usain Bolt, we have to do regular training, physical training, right? So you should have your protocols set in place for your ICU, role definition. You should have in between mock drills also, so that your team will be streamlined. Okay, the 3 scenarios. 1, life-threatening hypoxemia. See whether patient has a low physiological reserve, sick lungs, high ventilator settings, unstable hemodynamics. Our delivery is not matching the requirement when it comes to oxygen. Second scenario, we have some more space, life-threatening hypoxemia, but good physiological reserve, hemodynamic stable, and we are able to meet the requirement, oxygen requirement. And the last scenario is there is no hypoxemia, only the respiratory rate is high, maybe expiratory ventilation and asynchronous. We can take some more time to settle the issue. Okay, now can I have volunteers to discuss, because this is an opportunity for you to come forward.
Only Guru Prasad has raised the hand.
Dr. Krishnadas TV is also there. Guru Prasad, can we give chance to a newcomer?
Yes, sir. Yes, sir. Yes,
Okay.
Sir. No problem.
Okay.
Yeah.
Dr. Krishnadas. Dr. Krishnadas.
Dr. Bhagya. Yeah, Surendra. Dr. Surendra, can you introduce yourself?
Yes, sir. I am Surendra from Narayan Hrudayara, sir. I am doing DNB critical care, sir.
Okay,
I
excellent.
think we have met before also, right? In a previous session.
Yes, sir.
Okay.
Dr. Krishnadas and Dr. Bhagya, please unmute. Dr. Krishnadas TV and Dr. Bhagya. And Dr. Anwar Ahmad.
Yes, sir.
Okay.
Okay. Yeah. Anwar, can you introduce yourself?
Hi, sir. I am Dr. Anwar. I'm doing DNB critical care in Apollo, Hyderabad.
Okay, excellent. Yeah.
Okay. So I'll ask Dr. Surendra to take the first case. Okay.
Yes, sir.
Fine. So we have a 56-year-old diabetic patient in our ICU with severe ARDS. You can find that PF ratio is less than 120. Okay.
Yes, sir.
He is on volume control mode. FiO2 requirement is 80%. Tidal volume was set as 400 ml. PEEP of 16. Respiratory rate 28. IA ratio 1:2. We found that the plateau pressure is 31.
Yes.
Okay.
Yes, sir.
What is your assessment about his physiological reserve? Which category? One, red, green, or white?
He's in red category, sir. He's having poor physiological reserve because he's in a.
That is one you should know before you start. That is good. That is correct. I want you to appreciate that.
Yeah.
Okay. Go ahead, sir. Sorry
Fine, sir. So even before the alarm sets in, we know that we have less margin. Okay.
Yes,
we are walking on a tightrope. So now there is an audible alarm coming saying that there is a low pressure, low tidal volume alarm is coming.
Okay, sir. Low pressure, low tidal. That could be leak, sir, in this patient. Low pressure, low tidal volume.
Don't commit. It could be. You just see other parameters input.
Okay, sir. Fine.
Okay. So when we see the tidal volume, exhale tidal volume comes to only 250 ml.
Okay, sir.
Okay. Plateau pressure has also dropped to 25.
Yes, sir.
You can speak along.
Yes, sir. Yes, sir. I will check. I will check the graphics whether the patient is having any leak. If it is an ETCO2, I will check whether the sudden drop in the ETCO2.
Surendra, first FiO2 has to increase to 100.
Yes. Sorry.
Go systematically.
Okay, sir. First, I will increase the FiO2, and next I will check the graphics.
No.
Next,
clinically go systematically. Don't miss.
Actually, sir has explained, like first you see the chest, hear the chest.
Okay. Yes.
First go one by one. Don't skip you may see with experience. I will just look at something, not auscultating. But when you're learning, go systematically. You will always figure out the right thing. Next is how to proceed. Next is what?
clinical examination, sir. First, I will do the clinical examination. Next,
Okay.
I will see the ventilator parameters. In
No,
clinical examination,
what do you do?
I will auscultate the patient.
See the chest first.
See the chest, whether chest is expanding or not, and I will auscultate the patients. Next I will see the ventilator parameters, sir.
Okay.
First, always remember, see the chest, hear the chest.
Yes, sir.
That's
See
the
the chest.
drill. Remember the drill like that, you'll never miss.
Okay, sir.
Next.
See the chest. Next, ventilator parameters. What is the
So when we auscultated, chest is moving, breath sounds are reduced, but clear. Not much adventitious sounds at this point.
You want to connect the ambo or not?
Yes, sir. I will connect to the ambu and I will check the whether chest is rising, whether any difficulty doing the ambu. Or, not.
Are you sure?
See, chest is moving. There is reduced breath sounds. Chest is clear.
Chest is clear. I will. Chest is clear. So I will check any leaks, sir. Any abnormal.
Where is where should be the leak now?
It should be in the whether it in the airways, like tubings, any ET tube connection, or any humidifier, any ET tube and humidifier connectors, sir.
Okay, some leak is there.
Yes, sir.
Humidifier connector, how will you get usually leak in the ICU? HME?
Sir, there will be one small cap will be there, sir, in that.
Yeah, usually when you connect the ETCO2 and disconnect, if
Yes,
you're
sir.
not putting back that cap, it can produce leak. That is a
Yes,
common like place where it can leak.
Yes, sir.
No, yeah. Now the question is a sick guy. Do you want to disconnect and put a ambo or not ambo is my question.
Yes, sir. I will definitely. I will disconnect and I will put. No, sir. No, sir. No. If just I will see the next. I will see the ventilator parameters. If
Look at the SpO2. SpO2 is 82. See, why I am insisting that is this guy has a PEEP of 16.
Yes, sir.
And if you disconnect, all the PEEP will blow out.
Yes, sir. That's why I don't want.
You will have a saturation of 45. See, 82 for a ARDS guy is not going to die. So this is what I want you to understand, that every patient, every alarm, don't go and put an ambu bag.
Yes, sir.
Air is moving, breath sounds are there, saturation is decent. So try to rectify with the ventilator.
Yes, sir.
That is the point I want you to take home with this.
Yes, sir. I don't want to disconnect the.
Everybody says, I want to disconnect. Why? Saturation is decent, it's moving, breath sounds are clear.
Okay, sir.
You may just have to push the tube in a bit for all you know.
Yes, sir.
And once you remove and disconnect, all the PEEP is gone. Yes. And a patient may arrest. Remember
yes,
that.
Yes.
Go ahead, Saneesh.
Actually, our discussion started with this. Even before alarm rang, we knew that we have limited margin.
Yes,
patient is having severe hypoxemia, high PEEP, high FiO2 requirement. Okay. So you have to keep this in mind.
Okay, sir. Sure, sir.
Okay. So now we are going to find out where exactly is the leak, because the pressure is less, volume is also less. There is some volume loss. Okay.
Yes,
so how do you proceed systematically? Would you start from the machine end or patient end?
No. First, I will check from the patient, sir.
Okay. So you have auscultated, there is some air entry,
yes, sir.
But reduced breath sounds.
Next, first I will check from the patient end. Next, I will check from the airways. That is the connect airways. Next, I will check the ventilator, sir.
Okay.
Looking at that graph, what is your assessment now?
Sir, this
is a volume resistant.
Volume. There is a volume leak, sir.
So
volume leak.
Now you are sure it is leak, isn't it?
Yes, sir.
Now you want to see ETCO2?
Yeah.
Yes, ETCO2 is also showing some leak. Sudden drop in the ETCO2, sir. So
casually dropping. It's not sudden drop.
Yes, sir. Casually. Sorry, sir.
Disconnection, it will be sudden dropping.
Okay.
Or it's a pulmonary embolism or something. It can happen. Now it's gradually dropping. You're losing the contour. Usually, if the ET tube cuff everything is tight, you will get a good ETCO2 tracing. Now that edges are blended.
Yes, sir.
Okay. So now
diagnosis is leak, finding the leak, isn't it?
Yes, sir.
Okay, go ahead, Saneesh.
yeah, practically what do you do? So you will search the possible
Leak site, sir.
common leak sites. Okay.
The circuit all is intact. Then what do you check?
I will check the ET tube cuff, sir.
Yeah,
Cuff.
you put in a
Yeah,
tube, you put
okay.
in a scope and check.
Yes, sir.
Okay.
Okay.
You can auscultate over the trachea and listen for
Yes, sir.
leaks.
Leaks.
You want to suction this guy?
No, sir. No, sir. No, sir.
Because I have told you, when you suction, you are not only getting the secretions out, you are getting the
Pee.
PEEP also out.
Yes, sir.
Yeah, so you don't do a suction in ARDS unless it is indicated.
Yes, sir.
Remember that. Okay.
Sure, sir.
Okay. So
You
maybe
do a scopy, you see like this.
Yes, sir. Just
Cuff is half outside. What is your treatment?
I will put the tube little bit inside and I will inflate the cuff, sir.
Okay. So what did you understand? Two things you should remember from the whole slide, that every
In this, sir.
hypo-
Yes, sir. This is high. What I understood.
whatever it is, see, clinically the chest is moving, there is no life-threatening hypoxemia.
Yes, sir.
And some air is going into your alveoli. Don't disconnect initially, because this patient is much safer on a ventilator, because there is monitoring on a ventilator. On an ambo bag, there is no monitoring, and I have seen nurses pumping in 2 liters every breath.
Yes, it can damage the lungs.
Yeah.
So another thing, we will in a high risk patient, if the chest is moving, it's not correct to disconnect, because we will lose the P pulse. Sir.
Yeah, that
yes,
is it.
That,
plus the hypoxemia during the airway intervention also will be costly. So that decision has to be clear, and you should mobilize the senior most hand, the best expertise should be available, and we have to have crash cart and all the equipments ready in case you plan to do airway intervention. Okay. One more thing is, most of the ICUs, we check the cuff pressure during every change of nursing shift, approximately
yes,
8 hourly. So once we check, we'll also come to know that the cuff is good, okay or not.
yes, sir.
Okay. So if you have the habit of keeping the cuff checked every 8 hourly, then there is less chance of this cuff leak. Okay.
Okay, sir.
So now we are speaking about troubleshooting. Prevention of these mishaps is another aspect. Fine. So
Yes,
first we understood that scenario is we are dealing with a severe hypoxemia requiring good support, like high FiO2 and high PEEP. So your margin is less. So
Yes.
pressure is low, volume is low. Then again, we have decided that we are attempting not to disconnect and connect ambu bag. That option, we'll keep it only in the plan B. Okay,
Yes.
we'll try to troubleshoot with the patient connected to the ventilator to the maximum. So the first step is you increase FiO2 to the maximum. Then you start working up right from see the chest, hear the chest, then
Yes.
look at the
Ventilator
tracing parameters,
next,
graphics, and then
SP vote and
after,
ETC vote.
yeah, once we understand that leak is the problem, then you troubleshoot from patient end preferably. Okay, otherwise machine end will take more time. Okay, so here there is no question of doing suction, auscultate over the trachea, or you use a cuff pressure manometer, or you do a laryngoscopy, you will find this. So reposition the endotracheal tube, inflate the cuff. Okay, then
Yes,
you
sir.
see whether the alarm disappears. Your worrying factor was the pressure volume was coming down. If volume improves after this, well and good. Gradually you can come back to your previously set FiO2.
Yes.
Okay.
Yes, sir.
Fine. So
Yes,
you're
sir.
getting the sequence.
Yes, sir. I got the
Basically,
sequence.
it's practically what we do, but in exam also we have to have the habit of coming out with the answers. That is one thing.
Yes, sir.
Once your answers are streamlined, it will make more sense and you will save time.
Yes, sir.
Okay, that's the idea of this discussion.
Yes, sir.
Okay,
Thank you,
so
sir.
thank you. Shall I get Dr. Anwar for the next case?
Yes, sir.
Anwar, you are with us? Okay.
Yes, sir.
So this is the case for you. A 26-year-old A case of perforation, viscous perforation, septic, blood pressure is 90/60, tachycardic, heart rate 140 per minute, on NORAD infusion, CVP of 7 centimeters of water, and this is day 1. Okay, so
Yes,
viscous perforation, sepsis, low blood pressure, tachycardia, on support, on pressure control mode, FiO2 of 50%, pressure control above PEEP is 15, PEEP is 10, respiratory rate we have set at 18, IE ratio 1:2.
What is the plateau? What is the plateau?
Okay. So what is the plateau pressure?
Plateau is 15 plus 10, sir. Is 25.
Good,
Yeah,
good,
okay,
good.
okay, fine. Because we are dealing with the pressure control mode. So, fine.
Initially,
so now we
patient
get
is
an
an
alarm.
Yeah,
yes, sir.
come.
Yeah, go ahead, Enver.
Actually, first of all, the patient is an unstable patient because he is having hypotension on NORAD support.
Oh, you have triaged him as red.
Yes, sir.
Okay, fine, accept.
Okay, but his oxygen requirement and PEEP.
Lung is not very like a ARDS lung. It is not a ARDS kind of a lung. 25 plateau is decent lung. It is.
Yes, sir. And the tidal volume generated is.
I didn't put. You consider it is a decent lung.
Okay. So all of a sudden, your bedside nurse reports that alarm is coming. It shows high pressure and low tidal volume.
Okay, sir.
Now
And
you
the
can proceed.
saturations and other things.
We will go
Okay.
now. Tell how to proceed.
Yes, sir. Okay. First, increase the FiO2 to 100.
Okay.
Then do a clinical examination of the patient.
Okay.
With
Just see the chest. Remember, Anwar, talk like that. It will keep
yes,
it get into your brain. You always
see the chest.
hear the chest. See, it gets
Hear
into
the
your
chest.
brain. Let's have a
So,
kind of a drill now. I want
okay.
to remember the drill. Okay.
So what do you want to see when there is a sudden high pressure with volume loss? What do you expect?
I have to see the chest rise, sir.
Yeah. If you are looking for chest rise and
the symmetry of the chest rise.
Yeah, exactly. Yeah.
Okay. There is no
Symmetry of the
chest raise.
chest.
There is no chest raise.
Okay.
Is it a serious situation?
Yes, sir.
Yeah.
Okay. You're not getting chest rise.
That is why you don't require ETCO2 and pulse oximeter. Looking gives more information than all that. Remember, see here, remember that. That's the first step.
Okay. So you hear also auscultate.
Yes, sir. On auscultation.
So you find right-sided chest air entry is less.
Okay, sir.
So can you make a guess now? Day
Chance
1.
of a pneumothorax is there because the PP is high.
And somebody we have put as a CVP also, isn't it?
Yes, sir.
Yeah. Okay. That is what correlation has to go. Your junior has gone and put somebody, then you should know. CVP is there, suddenly it goes up, stable patient. You should correlate. See, clinical history and patient also makes to take you to the solution, isn't it?
Yes, sir.
Yeah. Go ahead, sir.
Okay, fine. So now you found there is a right-sided air entry is less. So now how do you proceed?
Sir, on auscultation, if the right side air entry is reduced, and to see the hemodynamics, if the patient's hemodynamics is worsening suddenly,
okay,
what you will do?
I may have to go for a that evacuation of the chest, like second intercostal space, needle percutaneous needle drainage of the air.
Go with a ICD tube, or will you put a needle?
I will put a needle, sir.
Because BP has crashed to 70/40, SpO2 is 80.
Yes, sir.
This is more of a situational driven. We are not sure, but it's situational driven, isn't it?
Yes, sir.
See, sometimes troubleshooting is like that. You have to do with what we have, because that decision, if you don't make, you call for X-ray, by the time X-ray comes, you may be collapsing, isn't it?
Yes, sir.
See, that's what I want you to understand at this point of time.
Yes,
okay, go ahead, Saneesh.
Okay, fine. So saturation has dropped and blood pressure is also dropping. So we have to do immediate intervention for your provisional diagnosis, which is the most likely case.
Okay, now we say that saturation is not dropping, BP is stable. We'll take it It's a small pneumothorax. Okay, we'll take it forward. Go ahead, sir.
Okay. Yeah.
Okay, sir. Then if the ultrasound machine is available,
What will you see? You put the next information, Saneesh.
Okay.
You want to disconnect the ventilator?
no, sir.
Yeah. So just don't, for every alarm, I want you to understand, don't disconnect and put a ambu. Okay, that's the 2 slides I made to impress upon the students that you don't require unless there is a issue where there is a block. Then probably you require to do it. Go ahead.
Okay. Fine. So on the ventilator, ETCO to curve looks like this.
Okay, sir. So there is a gradual fall in ETCO2.
Okay, fine.
Catheter mount is okay.
Okay, sir.
Next information.
So this is what you were telling, ultrasound. So what is the finding in X-ray?
Can you explain this ultrasound for the audience?
Me, sir?
Yeah.
Sir, actually, it is showing a classical pneumothorax picture.
What is it?
Normally, there should be a barcode sign.
Seashore sign.
Yes, seashore sign. So that is lost.
And if you can make out this point, this is called lung point. Where the changes to seashore sign to barcode sign, we call it as a lung point sign. This is pathognomic of
Pneumothorax.
You remember this, okay?
Yes.
So if somebody puts up and asks you in the exam, this is what you have to say. Okay.
Yes,
so now, see, you have got an X-ray also done because the saturations were not dipping. Now, how do you proceed?
Sir, I will go for
a needle now or put a ICD?
No, sir, I will put an ICD.
Where will you put?
Sir,
you have to put, no, where are you going to put? To the left chest?
The right
chest?
In the chest, sir, right side.
Then tell where. Can't say no, you won't put it now. Where?
Right side, and it should be directed towards the apex.
In which space?
5th intercostal space.
5th. You are sure? Here always goes up or down?
Always goes up, sir.
So why do you want to put at 5th intercostal space? Isn't it? Generally, we say 2nd intercostal space in the mid clavicular line, isn't it?
Yes,
put out the information, Saneesh.
Okay, one second.
That is for the emergency evacuation.
Okay, next. Okay, because there is ultrasound, you can put a small bore chest tube with ultrasound guided, because studies have proved you don't require to put a big bore for a pneumothorax evacuation.
Okay, sir.
Very small bore is enough. Anyhow, you have the machine. It can be done under ultrasound guidance.
Even pigtail will not do, sir. Now the small pigtails are there. Like
that is small bore. What Anoop is saying is like a small pigtail.
Okay, sir.
No, you are a critical care guy, no? So you should not speak in generals. You should be specific.
Yes, sir.
Okay, right. Next one, Saneesh.
Okay.
No, we are not trying to put you down, Anwar. We are trying to make you perfect. You understand?
Thank you, sir.
See, we want you to go systematically and be perfect, because in the exams, that is what we expect.
Okay, sir.
Okay.
Right.
Okay, fine. Who is volunteering for the case number 3? Dr. Bhagya, you're with us? Dr. Krishnadas? Okay, we'll go with Dr. Guru Prasad. Okay, because fine?
Yes, sir.
Yeah, fine. So this is a patient with organophosphorus poisoning on pressure support. Patient is receiving injection glycopyrrolate, stable. This is the ventilator settings. Pressure support mode, FiO2 of 40%. Pressure support above PEEP is 10, PEEP is 5. expiratory trigger sensitivity is set at 25 and the trigger flow is 1 liter per minute.
Okay.
Okay, did you get the scenario?
Yes, sir.
Yeah, fine.
Which
So you
zone?
are getting
Which zone he is in?
He's in the safe, in the least. His lungs are good. His hemodynamic means he needs a minimal requirement, and his lungs are good.
You can put it as physiological reserve is good.
Good physical. Yeah.
Okay, right. Next.
okay. Fine. So you are getting a high pressure, low tidal volume alarm. Okay.
Yes, sir.
What are the probable causes?
His other saturation and all are normal, sir.
We'll come there. Probable causes for people to.
Yeah, high pressure, low tidal volume is there is problem with the tubes or airways, sir.
Some block
Okay.
or bronchospasm.
Yeah, yes, sir.
Okay.
Endotracheal tube block or spasm. Airway spasm.
Something, some resistance issue.
Okay.
Yes, sir.
Okay. How do you proceed?
Okay.
That's what. If the saturation everything is fine, even then I would go with the increasing the effort to 100%.
Okay.
Then
fine.
I will do a clinical examination. I will see the chest rise, whether it is bilateral equal. Then I will auscultate on either side.
SpO2 is 76.
Then that's what. If I were to have increased, then clinical examination I will see whether the chest rise is there, and I'll auscultate.
So you're not hearing any breath sounds.
Okay. Then next is I'll disconnect the patient from ventilator and connect it to a ambu bag. With
Fine.
yes, sir. Then I'll try to ventilate the patient with an ambu bag.
So you're
If
not
still,
able to do the mask bag ventilation.
Yeah. If the there is no chest rise even with the ambu bag, then there is no problem with the ventilator. The problem is with the tubes. Okay, the ETCO2 is coming down. That means the tube is blocked. I'll try to pass
Go with suction or extubation directly.
I'll try to suction once.
I mean, saturation is 76. And look at the ETCO2 graph.
Okay, I'll extubate and try intubate to the new tube.
Why we are insisting is
yes, sir.
the time you require to suction maybe 1 minute. Even that becomes critical. So the decision has to be made with lot of knowledge and lot of thinking, isn't it?
Yes, sir. Yes, sir.
Okay, right.
After extubation, actually, we can ventilate him with good oxygen and then re-intubate him, sir.
Okay. Okay. Fine. So this was the tube which was removed from the patient.
Okay. That the end is blocked. There are secretions are there in the end of the tube, sir.
Yeah.
Why?
Okay.
Why do you think it happened? What
patient was on glycopyrrolate, so the secretions would have thickened and caused the blocks.
1, 2, HME, maybe
HME
4, 5 days.
Okay.
Maybe not working, so there is no humidification, isn't it? So
yes,
you have to go back and analyze why it happened also, not just solve. If you put a tube after 2 days, again same problem will occur, isn't it?
Yes, sir.
So how do you know HME is working or not at bedside? That's an important question, isn't it?
Yeah, yes, sir.
If you don't see the water droplets from in the suction, in the catheter mount, from the distance from your catheter mount to your tube, you will connect a catheter mount, isn't it?
Yes, sir.
The catheter mount should have small water particles. Then you know your HME is working. Normally, we allow HME to be used now to up to 72 hours.
Okay, sir.
So that you remember, that is important.
Okay, sir.
Okay. And level of hypoxemia determines whether to suck or not.
Okay, sir. Yeah.
Right.
Okay.
Right.
Yeah. Okay, thank you. Can we have one more person volunteering for scenario number 4? Dr. Bhagya, Dr. Krishnadas, your mics are allowed. You can introduce yourself. You can unmute and talk. Dr. Lakshmi Narayan. You are allowed to talk now. Dr. Lakshmi Narayan.
Yes, sir.
Okay. You are, can you introduce yourself for the audience?
I'm second year anesthesia PG from Salem, sir.
Okay, fine. So we'll go with the scenario number 4. Okay, this is a COPD patient on pressure support. Is hemodynamically stable, has a respiratory rate of 29 per minute, is distressed. You find an increased work of breathing. Okay.
Okay.
Okay, fine. He is on pressure support CPAP mode, FiO2 of 40%. Pressure support above PEEP is set at 13. The PEEP is set at 4 centimeters of water. Expiratory trigger sensitivity 25%. Trigger flow is set at 1 liters per minute. Rise time is 0.15 seconds. Okay, so this is the scenario: COPD patient on pressure support. These are the settings. Okay.
Okay, sir.
So you find the patient is in distress and increased work of breathing. Tachypneic 29 per minute. Okay. So you get an alarm saying there is high expiratory volume. This is a very common scenario, right? During weaning of COPD patients.
Yes, sir.
Okay. How do you proceed? The expiratory rate has gone up to 35. So which zone is the patient is in now? Red zone, very critical, life-threatening, critical, or reasonably stable?
It comes under the category of reasonably stable, sir.
Okay, fine. So as of now, there is no life-threatening indications, no severe hypoxemia is there. Hemodynamics looks okay. The only thing is he's gradually getting distressed and with increased work of breathing, possible going back to respiratory failure. Okay, how do you proceed?
We'll do the clinical examination, sir.
Okay. Okay, go ahead.
See the chest, hear the chest.
See the chest, whether the chest rate is equal, and we can hear the chest.
Why did you say it's equal? Because do you suspect some unequal thing when you get a high expiratory volume?
See, the high expiratory volume should tell that the ventilation is happening normally, isn't it?
Yes, sir.
It is happening because it is more respiratory rate. So probably he may be having pain, fever, he may be having anxiety, something like that. Or he may be getting too much support. Pressure support may be more than what he requires. So this is the things you have to consider. See, once you see high expiratory volume, as Saneesh said, what do you think if the lung is very poor? You don't get a good volume, isn't it? In a pressure support ventilation, if your alveoli becomes stiffer, the volume starts dropping because pressure is reached earlier and the volume drops. So if you're getting high expiratory, that means obviously the airway and resistance should be reasonably all right. That should be your assessment. That's what Saneesh raised the question. Okay, go ahead, Saneesh.
Okay, fine. So once you do the inspection and auscultation, said breath sounds are heard bilaterally, bronchi are present, which is not surprising for a COPD patient. Okay.
Yes, sir.
Go ahead.
We can give medical management like diuretics to reduce the bronchi.
You give diuretics for a bronchi? Think. It's a bronchospasm. What do you give?
Then we'll go with the nebulization, sir.
That's better, isn't it?
Bronchodilator therapy is better than going for a diuretic therapy. Diuretic therapy you reserve to pulmonary edema and things like that. Okay. Okay.
And we'll look for the saturation and EtCO2.
Okay. So you get the saturation of 92. Are you okay with this?
Yeah,
Saturation?
COPD patient saturation of 92 is reasonably, it's good, sir, actually.
Okay. So as sir mentioned, we have to rule out other causes or causes for tachypnea, like fever, pain, anxiety. So those are taken care of.
Do you want to increase the trigger to 4?
So this is one way of suppressing the breaths, no?
Yes, sir.
It's on the ventilator, not for the patient.
Would you advise that strategy?
No, sir.
Increase
actually.
trigger flow and so that the efforts die out?
No, sir. We can. We should not do actually.
Yes. Yeah.
Correct. Good.
Okay. Fine. So usually it's 1 to 2 liters per minute. So if you keep it very high, actually we are asking the patient to exert more to trigger a breath. So which is not acceptable. Okay, fine. That's good.
Go ahead. Go ahead. This is not required. Go ahead.
Okay.
Next. Next. This. Now what do you see?
Actually, there is an auto peep in the.
Good.
Okay.
What scalar is it?
Pressure time scalar.
Oh. This is pressure.
When you see something which has a representation below the baseline, it
sir,
is always
this is a pressure support, sir.
Yeah, no, we are speaking about the scalar.
It's scalar, flow versus time scalar.
Flow time, sir.
Whenever you see anything below the baseline, it is always flow. And it is flow versus time. Your diagnosis is correct. It is a auto peep.
Okay. There is air trapping, right?
Yes.
So how do you avoid that? One way is to correct medically, like bronchodilator therapy and all.
On the ventilator, in a pressure support ventilation, how do you correct this?
Increase the expiratory flow times.
Expiratory trigger sensitivity.
Expiratory trigger sensitivity.
At default, what is it set at?
Remember,
it is set at 25, sir, actually.
You want to make it 10 or 40?
It should be increased, sir, actually. It should be more 40, sir.
Yes, correct.
Okay.
Why?
So that there will be more time for an expiration, sir.
Very good. So something has worked. I'm happy that you are answering.
So, actually, now when the flow comes down to 25%, it goes for cycling. If we increase it further, okay, you can see the markings.
Yeah.
40% or 50%. So the cycling occurs here. Okay.
Yes, sir.
So basically your expiratory time increases. So you give more time for exhalation. There is more time for emptying of the lung before the next inspiration happens. Okay. So that's the idea of increasing the ETS.
Can you change any other setting?
Sir, we can increase the flow triggers, sir, actually.
That is done, no? It's that another thing is rise time.
Rise time.
Okay. Rise time is by default 0 to it's set at 5%, but you can change it from 0 to 20%. Meaning, in the first 20% of your inspiratory time, all the flow occurs.
Okay.
By default, you are set at 5%. But if you if you increase it to 20%, you can put it like this. See, if you have to run to one end of the room and come back, if you run fast while going to the wall and while coming back, you take more time. If somebody says you have 4 seconds, if I run at 1 second and come back at 3 seconds, so I have more time. So it is like your speed of your leg and the delivery of tidal volume. If you have an analogy, the flow rise time is nothing but if you increase it from 5 to 20%, within that span, 20% of your flow is delivered in a shorter span. So it is put it differently in different ventilators. For your understanding, rise time is nothing but inspiratory flow. By changing it, you tend to fill up the bucket faster in a lesser time. I have shown you the analogy of a bucket, isn't it? If you turn the bucket faster, will the bucket fill faster or smaller, lesser?
It will fill faster, sir.
So that is what, by changing the rise time, you deliver the tidal volume faster. You remember that? It's enough.
Yes, sir.
And you put the maximum so that you shorten the inspiratory time. Yeah, go ahead, sir.
Okay, for COPD, our idea is to have maximum expiratory time as possible. So you either make the cycling happen a little earlier, or with the present inspiratory time, inspiration phase, try to deliver the tidal volume faster so that you will get more time for exhalation. Okay, basically it's changing the IA ratio. Okay, we are manipulating the IA ratio so that we are giving more opportunity for exhalation, complete exhalation. So what do you infer from this graph?
There are some missed beats are present. Missed efforts.
Yeah, good.
Okay, missed breaths. Yeah, fine. So I think after we show this picture again and again in different topics, different contexts, I think people are getting more familiarized with the key points. Okay. Here we can see one effort is there that's dying out.
That was the idea. That was the idea.
Yeah. It's not converted into a breath. Okay. So what we can do now?
So clinically, don't forget, when you see a patient fighting with the ventilator, you have to go back and look at the graphics. This is important. Always don't think this will solve your problem. Always clinical assessment gives good information. Remember that.
Okay.
Yeah. Put the solution. Yeah.
Fine. If it is not solving the problem and patient is still getting tired, you try restarting on sedation.
And because auto-PEEP is there, and if he's getting too much volume, decreasing the volume happens only by decreasing the pressure support. In here, you don't have a control of volume, isn't it?
Yes, sir.
Because this may be because of increased volume. If you see, if he's getting about 500 ml of volume, that may be causing the auto-PEEP. Then decrease the pressure support. This fentanyl is, if you feel that he has some pain, is anxious, you give fentanyl to cut down the respiratory drive. Yeah, go ahead, Saneesh.
Okay. It's not with the higher trigger sensitivity. Okay. It's with some sedation and correction of the primary cause. That should reduce the tachypnea. That's the idea. Okay. So ETS or expiratory trigger sensitivity, we can increase to 40 from 25% or rise time to 0.4 seconds. Okay.
And if he's not settling down, still what can we do? If he doesn't settle down with all this.
Okay. Dr. Lakshmi Narayan.
Put up, I think is
Dr. Lakshmi, with us?
Yes, sir.
Yeah, the question is, if patient is not getting settled with all these measures, what's your next step?
I'm not getting the question, sir.
No, we have tried to change the ventilator settings. We have increased the ETS to 40% from 25%. Rise time is changed to 0.4 seconds. Still patient is tachypneic and you are not able to settle down. The patient is not settling down.
Then we can put the patient on an invasive mode, sir.
Invasive, everything.
No, we can intubate the patient and we can ventilate the patient.
Patient is already intubated. We have not come up to the extubation time. Tube is already there.
See, what you said, the first one is correct. You can go for a more controlled mode. That's what you meant, isn't it?
Yes, sir. We can say paralyze the patient and we can go for controlled mode.
Need not paralyze.
You can deepen the sedation and go with a pressure controlled ventilation for a while. Maybe his pain or anxiousness will settle down. And even with that, if it doesn't settle down, probably you may require to go with paralysis or intubation, but it rarely happens. So you can settle him down with these measures, most of them.
Okay.
Yeah.
Okay, fine. Okay, thank you. We'll go with the next some more.
Enough.
So regarding the missed breath, you change the PEEP settings also. Can I have one more participant for our last scenario? Dr. S, you are with us? You can introduce yourself.
Hello, sir. I am Dr. Sandhya. I am first year DNB Critical Care Medicine at Medical Trust, Ernakulam.
Okay. You are from medicine background or anesthesia background? Primary candidate.
Pulmonology.
Pulmonology. Okay, fine. So this is the scenario. Dr. Sandhya, right?
Yes, sir.
Okay. This is a 70-year-old gentleman with who underwent total knee replacement 2 weeks back. He's a diabetic. He develops community-acquired pneumonia, septic on ventilator. His echo shows normal limits. These are the ventilator settings. FiO2 of 40%, pressure support above PEEP of 12, PEEP of 5. Expiratory trigger sensitivity we have kept at 25%. Trigger flow 1 liters per minute. Rise time 0.15 seconds. Okay. The scenario is clear?
Yes, sir.
Post TKR, community acute pneumonia, diabetic, septic on ventilation. Okay. He becomes restless. Saturation drops from 95% to 88%. Blood pressure is dropping from 120 by 78 to 90 by 60. On auscultation, bilateral crisps, air entry, bilaterally equal and good. How do you proceed?
Any probable diagnosis?
Pulmonary embolism has to be considered.
Yeah, isn't it? TKR 2 weeks back, probably bedridden, isn't it? Elderly gentleman. See, that is, history is always important in troubleshooting. Never ever leave the history and clinical examination. You will never arrive at the correct situation if you miss those two things. You should know your patient. You should hear and see the chest. You remember that. Okay, go ahead.
Okay, fine. So you see the chest, auscultate the chest. Okay. So what you find is air entry is good.
Some traps are there.
Okay. So how do you proceed?
If it is pulmonary embolism, what is the tentative diagnosis? How do you proceed now? Because there is no life-threatening hypoxemia. It is 88 saturation for a 70-year-old gentleman. And you are saying that you have pulmonary embolism as a suspect. How do you proceed?
The patient is actually doesn't have any life-threatening hypoxemia, but he's becoming hemodynamically unstable.
Can you confirm with looking at the parameters you have in hand and make more, it's an educated guess now. Can you make it more, the diagnosis by looking at some parameters? Which parameter would you like to see in a pulmonary embolism situation?
We'll have to do echo, repeat echo.
Okay. What will be the difference between PSCO2 and ETCO2?
It will be more than 6.
Isn't it? See, something, you get a ABG, you become more sure that you are going somewhere there, isn't it? See, ETCO2 has dropped from 45 to 33.
Okay.
And if you do a PSCO2, ABG and check, so that gives a clue, isn't it? It's not confirmatory, it gives a clue. Okay, next. Any blood test you want to do? What is the difference now?
PCO2 is more than 10.
So probably you are going in the right direction, isn't it? Before investigating and putting so much of money getting a CT angio, it is better to be sure, isn't it? Okay, next.
Okay. Fine. How do you proceed?
We can
confirm the diagnosis.
We can do a bedside echo and see the
What will you find in echo?
RARV may be dilate.
Okay. That is the investigations you would order. Go ahead, Saneesh.
Okay, D-dimer, echo, CT angiogram to confirm. Okay.
D-dimer is confirmatory, Sandhya?
No, sir.
Yeah, isn't it? Especially in a post-surgical situation, it may be raised because of the sepsis and surgery. So echo. Go ahead, Saneesh. So echo, these are the signs.
Okay, RV dilatation, RV hypokinesis, sparing of apex, McConnell's sign. Can you explain? D-shaped left ventricle, TR, raised pulmonary artery pressure.
Isn't it? These are some of the things we will look at, isn't it?
Okay, fine. The echo picture is given there.
And confirmation is always by probably CT angio, isn't it? Yeah.
So it's all started from our alarm and we reached the diagnosis. So that's the beauty of listening to the alarm. And you should have a structured protocol how to tackle when your ventilator gives an alarm. Is it clear?
Yes, sir.
Okay. Dr. Anoop will wind up the session.
Tomorrow we are not doing the mechanical ventilation. We have postponed it for Friday. And Friday will be case scenarios again. ARDS, COPD. We will take you through on the first day, second day, how to wean, how to extubate, how to maintain. We will integrate fluids, nutrition, everything. And we will do the scenarios on Friday.